We are live from Studio 11, Auckland Park, Johannesburg, Gauteng. Only thing that's missing from that intro is the GPS coordinates, isn't it? We are ready to engage with you on matters that affect you and matters that affect your family. And your health matters. And that makes it topical. Good evening to you, South Africa, those watching around the world. My name is Blaine Herman, and this is It's Topical. We're also live on SABC Plus, our digital audience with us tonight. Good to see them. Remember, our digital audience is made up of members of the public who've expressed an interest, a keen interest in our topic of discussion. So we invite them to be part of the show, to observe, as well as to ask questions to our guests. So please do get those virtual hands up, and I'll do my very best to get you on air. By the way, those living in Gauteng, did you feel that during the early hours of the morning? Woke me up. A seismic event occurring in the East Rand. We're going to give you some more details on that in a short while. Stand by for that. All right, let's shake things up in a different way. Our main topic: how are you treated when you visit a hospital, when you visit a clinic? Do you get a sense that you are a priority and that your needs are put first? The public healthcare sector, it continues to face significant challenges. Why? There's a number of reasons. One of it is trying to meet the demands of a rapidly increasing population size. The impact of inflation and the state of the country's economy are also contributing factors in some of the sector's limitations to service delivery in healthcare. What are the quick fixes? What are the long-term solutions? We will discuss. Which leads us to our question of the week, popping up there on your screen. With newborn babies recently pictured in boxes and reports of almost 800 infants dying in Tembisa Hospital since 2020. Question: is quality healthcare still a pipe dream for some communities in South Africa? What are the solutions? That's what the whole program is all about. We give you the problems, but we need solutions as well. Come, context, always important. With regards to the healthcare system, how stretched do you think it is? How burdened do you think it is? What about nursing? Is it still regarded as a vocation? Or, people normally used to see it as a calling, life's work, purpose. Or has things changed? How relevant is that in this day and age? We will discuss at It's Topical SABC Perspective. Coming up now, time for your roundup. Yep, the earth shook literally in the early parts of the morning. This is where it was. Gauteng struck by an earthquake of a magnitude of around 4.4 just before 3 a.m. in the morning. The epicenter was in Gauteng's East Rand, but it was felt in the center of Johannesburg as well as the north and west of the city. And it was also, we understand, felt in Pretoria. Take a listen.
In Johannesburg, this will be the first one in 6 years. So 6 years ago we had one. It seems like they are increasing. We must remember that the plates on the earth is moving, and I think this is probably related to the quakes in Turkey that was very, very serious. The African plate was associated with that quake. And it is highly possible that our plate has just now rebounded a little bit because of that quake, and that's why we have this move of the plate that bounds. The crack runs from Mozambique to Joburg to East London, and it's probably just a rebound and a little bit of a shaking of these plates because of the major quakes in Turkey. My personal view is that the earthquake epicenter is at about 10 to 17 kilometers underground, and none of our mines is that deep. So there's a serious movement which happened at 10 kilometers underground. How serious the earth actually moved in Joburg because of the mining as a consequence of the earthquake, that they will determine in the next 5 or 6 days.
Look, there was a lot of activity on social media, isn't it? As early as this morning. I know a lot of WhatsApp groups were on fire this morning, in early parts of this morning. A lot of people felt it. It almost felt like a train was passing you, right? You had that vibrations. I know my cupboards were vibrating. But some, as you can see, slept the whole night and morning, didn't feel a thing. But we're told in terms of the aftershocks, it's something that was very interesting that our guests mentioned. During the time of COVID, where things were pretty quiet and people were, working from home, you used to get a sense, or you used to feel these tremors or earthquakes more often. Now with the hustle and bustle, it becomes harder to pick up. But that's the state of play. We are relatively now in a safe zone. That's what we are told, but we will keep you updated with any developments regarding this. Now, to our main topic. All right, let's get you a sense of what we know and why it matters. We're talking all things health. I'll pull up a few slides to better illustrate context. As you know, context always important on this program. With regards to the findings, medical negligence claims against public healthcare sector, right? This is according to the Auditor General Report 2021-2022. As you can see, over 855 million rand paid in 2021-2022 for medical negligence and malpractice. Total cost of claims against healthcare sector, over 103 billion. Big numbers we're talking about here. Shortage of medical experts and the medico-legal officers contributed, we're told, to the delays in claims finalization. What about the issue of the number of people that are on medical aid? We're told, according to the 2020 General Household Survey, only 17% per 100,000 South Africans have medical insurance, which means the majority of the population, 80% of the population, rely on public healthcare sector. So that's important. It sets up a conversation very nicely when we're talking about the NHI. That's more coming up. With regards to challenges facing the public healthcare sector, right? These are the issues that have been listed. Human resources and understaffing, big issue. Health financing and budgetary constraints. Medical negligence related claims. You saw that earlier on. Maladministration, corruption, and wasteful expenditure, aging and ailing infrastructure, and a lack of equipment maintenance. High rate of vacant posts, cited as some of the concerns, some of the challenges that has been listed in terms of the healthcare sector. And this is what we're talking about in terms of patient experience. And we want you to engage with us with regards to when you visit a clinic, when you visit a hospital, what sort of treatment do you get, apart from medical treatment? The process that leads up to that. Talk to us about that at It's Topical SABC. And here, many people talk about the issue of safety and the issue of long waiting periods, understaffing, hostile and discriminatory treatment, contributing factors that directly affect patient experience at the public health facilities. All of these issues we will be discussing as well. So context, as always, matter, perspective coming up in a short while. Now, with regards to what you have to say regarding this, let's go to our regular feature. It's called the Word on the Street feature. And we took to the streets to get your take on the healthcare issues and your experience on the streets. This is what you had to say.
We were promised free health care, but now it's free death. Every day people are dying. The government is doing nothing. They have to do away with the tenders and take the health institutions in their hands to safeguard our lives.
Due to multiple misdiagnoses, I was informed that I had cancer and underwent several surgeries. However, I am currently not undergoing any cancer treatment. I am not sick.
I think they must hire the staff and the people that they have experience to help the community. You understand? So they don't do that. It's the problem that we have.
Inkinga enkulu engibona ukuthi we are facing management
Main problem we have in our health facilities is mismanagement. Patients are just mixed up and facilities are not even clean.
It's dirty. We can see that, at times then they cannot handle what is happening in those hospitals because the hospitals are overcrowded. And the overcrowding is a result that the personnel within those hospitals, they are unable to deal with the pressure that comes with the overcrowding.
Foreigners are often given first priority and special treatment in our public facilities because they can pay bribes.
And then it's a problem.
Being in the healthcare center is like a passion, but people who are working there are clueless at the moment. They are very clueless. They no longer have the concern for the people. They're just concerned about money, that's all. I think the government has to intervene and relook into the whole situation.
I think abantu abekho committed. They're not doing things out of love. Mangaba na that babe committed, things can be better.
So that's your reality on the ground with regards to the services that you receive at hospitals, at clinics. But it must be stated, there are a lot of good men and women out there willing to help. You saw it during COVID. They put their lives on the line in order to help society. But we will discuss where we can augment or mitigate in terms of getting to better, as we always talk about. Let's discuss this. Is there a doctor in the house? We have two, in fact. Dr. Nicholas Crisp, DDG of National Health Insurance, the National Health Department. So good to have you on the program, as well as Dr. Ntuthuko Bhengu, founder and CEO of Alchemy Health Technologies. Online is Michele Clarke, a DA Health Shadow Minister, is also our guest. Thank you, Michele, for joining us, as well as the digital audience. Just a reminder, we have got a limited time, so if you can get those hands up as soon as possible, we'll get your comments in a short while. Thank you very much indeed. Lots to discuss. Dr. Crisp, to you first. With regards to, let's get a sense of where we are. Maybe let me just start with you, Dr. Bhengu, rather. Sure. You on the ground, working at various hospitals, you have a pulse, you have your finger on the pulse. To what extent is the healthcare system stretched or burdened, in your opinion?
Thank you very much, Blaine, and I just want to greet your viewers as well. I think the issue here is that practitioners, like everybody else, want to make sure that they work in an environment where there is leadership, where the environment itself is actually a pleasant one. And of course, there are the issues, hygiene issues, like, of course, what's important, remuneration. And also, for a system that works for the patient as well. That is also just part of the issues that I believe make up an ideal healthcare system. And obviously, ultimately, it's also about health outcomes. But the issues of how the system appears and how it is friendly towards the patient is definitely a critical one, and one that I believe we have a lot to do to get right.
Dr. Crisp, having heard that, I guess it just sets the scene to what you here to talk about, which is NHI. How far are we from fully realizing the national health insurance here in South Africa?
Yeah, thanks, Blaine, and good evening to you and to the viewers as well. I think we need to understand where we have come from and the complexity of the health system that we find ourselves in. We have a very complicated health system, and it's going to take a long time for it to be realigned and reformed. Part of the problem is that we have 9 very separate provincial departments who get their budget from the central fiscus, not through the National Health Department as it was in the past. And we have 76 medical schemes who fund healthcare directly in the private sector. The result of that is we spend about 5,200 Rand per capita in the public sector, and we spend about 27,000 Rand per capita in the private sector per annum. These are incomparable amounts, and you can imagine the stress on the staff who work tirelessly in the public sector to try and deliver a good service. So what we want is we want to reform the entire system. where we pool all of that resources and you get the healthcare that you need, when you need it, where you need it, and not just because you've got money. And we don't want a situation where even those of us who are a little bit better off end up in financial hardship because we didn't anticipate our illness when we signed up for a medical aid package. So this will take a while. On the 24th of May, we had the voting in the Portfolio Committee on Health, and I'm sure Honourable Clarke will talk about that in a moment. And as a result of the resolution in that committee, the bill goes to Parliament, to the National Assembly, for the vote on Tuesday this coming week. Then it goes to the National Council of Provinces. In the meantime, there's a huge amount of groundwork to be done, and that is what we are now embarking on. Obviously, strengthening health system where we can at the moment within the resources available, but also planning for the reforms that must come.
Speaking about the groundwork, what sort of feasibility studies have been conducted so far, and what sort of outcomes?
So we've been and looked at many countries, we've spoken to many, we've worked with the World Health Organization, and they said the only thing that's not feasible is to continue with your current system. We spend 8.5% of our GDP on healthcare, and we get outcomes that are comparable with countries who spend less than 10% of that as a per capita spend. So the problem is we are not getting health outcomes. We are not reducing our maternal mortality. We are not reducing child mortality fast enough. We are not reducing infant mortality fast enough. And there are many other indicators, as my colleague Dr. Bhengu was talking about. Those are the indicators of health. So while you might see nice, clean things in the private sector and dirty in the public sector, those are not the only things you have to measure. You have to measure whether the public, the patient, 61 million people are getting the health care that they need.
Let's bring in Michele Clarke. From what you heard from Dr. Crisp, the only thing that's not feasible is to stay on the current trajectory and continue with the system that we have. Agree, disagree? If you can unmute, Michele. There we go. Go on.
Thank you very much for having me on your show, and good evening to your listeners. So yes, Dr. Crisp and I often butt heads on certain things, and we do collaborate a lot on the same committee. First of all, no feasibility study has been done at this stage because, as far as we are concerned, in terms of the portfolio, that feasibility study has never been presented to the portfolio. We've asked many times for National Treasury to please come and present the financial model in terms of NHI to us, and that has also fallen on deaf ears. So at this stage, none of us are aware of what NHI is actually going to cost this country, what the tax burden is going to be on the taxpayer, because the taxpayer in this country at the moment is completely, strained in terms of the economics of this country. So, those various issues have not been communicated to us, and until we know exactly what this model is going to cost us, we can't support the NHI as the Democratic Alliance, although there's many things we can do in the healthcare sector in order to ensure that we improve our healthcare in terms of what's happening, because I think our healthcare is crumbling, and the kind of service that we are giving to patients is really unacceptable, because our healthcare is on life support at the moment in this country. And if you take 9 million people that are on medical aids currently and they bring them over onto the state system, that's going to place an enormous amount of burden onto the state public healthcare system, and therefore, that is one of the very big concerns we have. And there's many others, but I'm sure I also need to give your other guests space to speak.
I just wanted to put something that I think you penned an open letter, DA penned an open letter to the president, something that jumped out at me, and I just want to read it out quickly. You say, in fact, just by taking away a person's medical aid will mean that their medical tax savings credit from having a medical aid will be removed. The result, every one of those almost 9 million people with medical aids would now be paying an additional 4,368 of tax every year at a minimum. And this is before any further taxes are levied for NHI itself. How do you respond to that, Dr. Chris?
Well, there was a decision some time back that we should have removed the tax credits already, because what is the point of subsidizing people who are already using the private sector and who already have privilege and access to a different system? Why not redirect that 37 billion rand per annum and use it to strengthen the public health system for the 85% of the population who is going to use it? So that, I mean, that would be the argument. The whole purpose is not to use more money in the health system, but to redirect it and to generate savings. Part of those savings comes from efficiency, of not having 9 parallel departments of health doing separate things that all cost. Part of it is from not having 76 medical schemes that have to be administered. The cost of that is 15% before you provide any health care. And part of it is because if we had one record that you and I and every member of the public, if we move around and get services in different places, why do we have to have our x-rays repeated and our blood tests repeated and our examinations repeated? This is a complete waste. So we all know, and we have discussed this many times, there are huge savings if we just get a streamlined system and if we all have one benefit, so that we all know that that's the benefit we are going to get, and we don't have to have a situation where you have to guess what is going to be wrong with you in a given year.
The issue that Michele raises with regards to not being forthcoming about whether this country can afford the NHI, why hasn't that information been put forward?
Yeah, but it has. You see, people don't want to hear that 8.5% of GDP, which is 500 billion plus, so close to 550 billion spent this year. That's the envelope. That's what we need to plan within. 265 billion of that is currently spent in the public sector, and 277 billion is currently spent the year before last in the private sector. Some of that through medical schemes, but some of it out of pocket. So if we took all of that money and we use it more efficiently, that is the point. So if you are moving a voluntary contribution to a medical scheme where you have no clue what you are insuring yourself for, and you put it into tax, into a general collection where we all use that money for everybody, and we're not suggesting, and the bill does not say it will be a nationalized public system. Everybody knows that the bill is very clear that it will be public and private delivery system, but a single finance system for the package for everybody. So I think it's disingenuous to say we've never discussed this. You don't calculate the actual rands of today when the bill will start to be implemented after the NHI will be implemented after the bill becomes an act and over many years. So it's not feasible to do it like that.
Dr. Bhengu, is that fully understood, what Dr. Crisp is saying, fully understood in the medical fraternity?
Yeah, well, from the perspective of whether we have seen a fully costed bill, we haven't seen that. Certainly not in a manner that has been widely publicized. But I do agree, of course, that the universal health coverage is desirable. But my wish is that our regulators, when moving in that direction, because universal health coverage is not a destination, it's a direction, which is why I tend to agree with Dr. Chris on that point as to whether we just need to wait until we can afford everything. But I wish the department wouldn't pick and choose what's in the WHO recommendations regarding universal health coverage, because part of it is about starting where you are. And where we are is a very vibrant, even though it's not completely even though it's not without fault, but it's a private sector that also works. And the issue of moving into a dispensation where the private sector, at least aspects of it, are excluded, I do not think that's in line with the view that said start where you are. There are regulations that are out to make sure that that is fixed, but that has to be part of our solution going forward. And I must state, I do not mean that anyone who's got an income mustn't contribute towards NHI, because universal health coverage is critical. But if after contributing to the NHI, you still want to spend out of your dispensable income on healthcare, that should be allowed. I do not see how that's a disadvantage, because you do have a system that you have a good chunk of people who are paying towards but are not using. At the very least, it helps the system start off the ground with fewer users than there are payers. So I don't think that in that regard, but also I'm in between, because I also am not fully in agreement with our colleague who's also spoken from the perspective that you cannot start until you have all the money. I've referred to the point that universal health coverage is a direction. And the example I always use is that it can't be true that Sanral can't start building beautiful world-class roads until every village has got a tarred road. We do need to start. My concern is that maybe our version of universal health coverage, when you call it national health insurance, our scope is narrower than it needs to be, because the problems that we can deal with are also structural, are infrastructural. I fear that maybe government is sleeping on a very good sort of program on ideal clinics rollout. That's funded, but we are seeing regression, and that is primary care. That does not even need what you would label NHI, but it's there and it must be capitalized today. That's what I'm talking about. When you talk about direction, there are many facets to this.
Look, there's lots of issues or lots of aspects with regards to NHI. And I think in order to fully understand it, you need to have more information forthcoming. You need a buy-in from the public, because you don't want it to end up in a rich versus poor situation. Everybody needs to come on board if this thing is going to work. We need to take a quick break. Matimo, I see you. Glenda, I see you as well. We're going to come back with the digital audience. What will it take to fully realize the dream of perfect healthcare system? I don't know if that's even plausible in terms of worldwide, but we need to get better. We need to get to that better place. What sort of steps do we need to take in order to get there? We're going to come back, get the digital audience take as well. Stay with us.
We are making this law for the children of our children. This country will stand firm.
The bill doesn't allow for any queer survival in Uganda right now. We have been stripped of all of our rights.
It imposes severe punishment for same-sex acts, including labeling some acts as crimes punishable by death.
No one should be attacked, imprisoned, or killed simply because of who they are or whom they love.
We are saying to Museveni, leave the people the way they are.
This is the mistake of Western countries. You can't put up with their nonsense.
Welcome back. We're talking about the public healthcare system tonight, the sector, as it continues to face significant challenges. And what we are asking you is, with regard to reports of these newborn babies recently pictured in boxes, right? Disturbing. Also reports of almost 800 infants dying at Tembisa Hospital since 2020. Is quality healthcare still a pipe dream for some communities in South Africa? And what are the solutions? Let us know at It's Topical SABC. Our guests here tonight answering questions. We need to get to that better place, but we also got digital audience as well. Let's get to them straight away. Matimo, to you first. Your take on the discussions tonight.
Thank you so much and good evening. Thank you once again for having me. It should be noted that the right to healthcare is a constitutional right and a basic human right. So the government has an obligation to ensure that there are programs in place, there are initiatives in place, and there are policies in place to ensure that the state of public health is improved and is of good quality, and is also, and the safety of the public is guaranteed. We should not speak about these issues in isolation of the government of the ANC. We are in this mess just because of the incompetence and the corruption of the ANC. Where we are sitting now, the public health or the health system in our country is collapsing. The issues of Tembisa Hospital and Mahikeng Hospital is just an indication of where we are as a country and the state of our the public health. And also the findings of the SIU in relation to public health are just a clear indication that the government of the ANC is failing us, because we have people who are being turned away in hospitals, we have prolonged waiting periods, understaffed, the issue of maladministration. And I think one of the things that we have to do is to ensure that the decline in the increment of legal cases, we should ensure that those numbers decline so that the money can be used to fix other issues. And also the vacant position in senior management of hospitals, I think that's also an issue that has to be quickly attended before we collapse the healthcare.
Matimo, thank you very much indeed. Glenda, Matimo raises the issue of competency. From your perspective, do you think it is a case of a shortage of money in some cases with regards to the services you receive at hospitals, or a shortage of competent and honest management to run those hospitals?
I think it's both of those issues, actually. As Matimo said before, the issue, we can't look at healthcare in isolation. As he mentioned, we need to look at what contributes to an overwhelming number of patients that are reliant on the healthcare system. So we need to backtrack, because healthcare is just one aspect of that. So backtracking includes looking at water, sanitation issues in communities, looking at safety and security of women as well when they come and how they're treated in those healthcare facilities, and overall food security, poor service delivery, load shedding, all kinds of issues like that. So all of these factors that happen before we even look at the healthcare sector, we can't just look at it in isolation because it's all related. Even if you look at the issue linguistically, when people mention private hospital versus public hospital, we already associate positive connotations with private hospitals and not so good ones with government hospitals. If we look at it, we need a complete mind shift change in how we look at these problems. We need like a social justice approach as well. So I think that there are a lot that contribute to it, and as Dr. Crisp mentioned, it is quite a complex system, the issue of healthcare in South Africa, and it needs like an all-rounded interdisciplinary approach to actually solving that problem for communities.
All right, Glenda, thank you very much indeed. Matthew, to you, and then Neo. Matthew first.
Well, thanks, and good evening to the listeners. Look, I think as COSATU, we strongly support a move towards a national health insurance. We're looking forward to Parliament passing the NHI bill, the National Assembly next week and the NCP by the end of the year. It's not going to be overnight achievement. It's going to take a long time in terms of legislation, putting in place the resources, the systems, and so forth. But I think right now, if we're talking about the issue of resources, we should be asking, can we continue to afford a scenario where we spend about over 250 billion rand on about 15% of society's healthcare, and a similar amount in the public healthcare institutions providing for the other 85%. That's not sustainable. People are dying of easily preventable diseases. We should be asking ourselves, why are we the tuberculosis capital of the world here in Cape Town? So there's also a huge impact, not just on the fiscus, but on the economy, on the productivity of businesses, upon workers' lives when their family members die prematurely, when families lose breadwinners and so forth. So the system, as Dr. Crisp is saying, we can't continue. We need to move towards the NHI, which means that we can have the resources to make sure we're pooling resources equitably. We're focusing on primary healthcare. We're making sure we fill our nurses or doctors' vacancies. We should be quite alarmed by the amount of brain drain we're experiencing currently, where huge numbers of doctors, paramedics, nurses are moving overseas to better paying jobs, which are less stressful. So I think for us right now, we should be prioritizing our investments in healthcare. And we've seen, maybe lastly, people always want to demonize the state. But if you look at the South African Revenue Service, when government invested more money in its IT capacity, filling vacancies, deploying competent management, we saw a massive turnaround in the productivity level of SARS to everybody's benefit. We took a similar approach in investing in our public health care. Society will be better off, as we saw during COVID when we were struggling. Then we expected nurses and doctors to perform miracles. We expected them to save thousands of people's lives. And we were all shocked when nurses and doctors are having to make judgment calls in parking lots on who to treat, who not to treat. So we shouldn't be putting our nurses in that kind of a situation. We should really be investing in our healthcare as a society. We should not be quibbling about what does it cost and why should we or should we not do it. It should be a moral issue.
Yeah. Matthew, thank you very much. Neo, and then Piwa.
Good evening to the viewers and to everyone in studio tonight. Thank you for the opportunity. I would like to address firstly, let's firstly view what happened at Tembisa first of all. It is seen that we're talking about the government having to have invested so much. It has invested so much, and yet we still see an incompetence and also a misuse of fundings that are being given to these hospitals. Firstly, we talk, if you look at the reasoning that they give for what has happened with the babies or the young children, they talk about it having happened because of the shortage of staff. If you listen to such a reasoning, we talk about shortage of staff while there's like more than, I can see more than 10,000 or 5,000 students that graduate that can serve within these vacancies that we see in hospitals. And why do we still have shortages if we have so much students graduating and people to work in the sectors? And now we see that Dr. Mahuba has, a professor, should I say, Mahuba, has stated a very funny point about the national health insurance, that it's very incompetent and it lacks. To a certain extent, I would like to agree, as we still see social injustices within the healthcare system. People go to certain hospitals because that's what they can access. And that's something that should be addressed. You find that someone has to travel more than, 10 kilometers to a hospital. That's a matter that we should also be addressing. Because now you find that we talk that Kempton Park Hospital has been closed. That's why you have the number of people going to Tembisa Hospital. Why is that so? We don't have hospitals in certain areas. That's why you find that certain hospitals are filled up with so many people. And so I feel like we're focusing on other sectors. Well, the most important is how many hospitals, firstly, do we have? And we're talking about the resources. There's so many people who can fill so much vacancies. There's so many people to work, but then employment is also a contribution to it as well.
Look, there's a lot of issues. I'm going to put some of your questions to Dr. Crisp as well. Let's get Piwa Nkosi.
Okay, thank you very much. Greetings to the viewers and the panelists. I'm just going to stick mostly on the stats that about 17% of South African have medical aid. And of that 17%, about 10% are black people. So it's one of the things that we need not to separate the type of inequality that also exists within the type of system we have in South Africa in the private and the public sector. So that when we are thinking of solutions to deal with, we ensure that we stay true to the ideals of trying to create an equal society. Secondly, in the 17, I'll just give an offset of 20% of the private medical people with private medical aid, about 20% having access to private hospitals. Out of that 20%, they are being serviced by 80% of the doctors, 75 to 80% of the doctors in South Africa, which means 20 to 25% of the doctors in South Africa are servicing the other 80% of the South African population. And with those stats, where wouldn't there be any negligence? How would because it means that our doctors are being overstretched, they are being overworked, and all those things. And when you take all that, you are servicing 80% of the population, and there's 20% of you. There's bound to be negligence. So I think we need to also look into ensuring that there's an equal distribution of resources in terms of expertise and doctors to cover the need that South African has in terms of
Just some clarity on that figure that you gave us, Piran Nkosi. It is only 17 per 100,000 South Africans that have medical insurance. But look, the vast majority, 80%, do not. I'm going to get some comments in a short while from my guests. Can I take Dr. Cedric? If you can unmute, sir.
Thank you very much, Blaine. I'm representing the Doctors Union. I think I'm very happy with the points that have actually permeated, especially speaking on the large number of patients who access the public healthcare system who unfortunately have to be serviced by a very minute number of healthcare, comparing that to private. We've always made the point that it's a bit unfortunate that the bulk of patients, the 80% of the population, will use these hospitals, which unfortunately are very, very underserviced and understaffed. Now, we've made the point numerous occasions as well to say it's so unfortunate that as it stands, you still find healthcare workers who are sitting at home unemployed in a situation where they should actually be servicing the bulk of our population.
Yeah.
So it's the NHI for us as Doctors Trade Union Smarties is actually welcome. I think it should be something that actually gets expedited. We understand that the implementation of it might take a bit of a while, but the sooner the better, because as it stands, we are losing patients, and unfortunately, healthcare is a matter of life and death. So I think that solution that is on the table now, the NHI, it must be embraced, and we must all put our hands together and ensure that it actually finds fruition. Thank you,
Doc. Thank you very much indeed. Kaya, let me get your take, and something that has been popping up a lot. Some of the comments that we've seen in terms of attitude from nursing staff, etc. Do you think nursing in this day and age is still a vocation? It's still a life's work, life's calling, purposeful? What's your take on the ground? What are some of the frustrations on the ground?
Good evening, Ben, and to the viewers and the guests. Ben, yes, nursing is still a calling. However, the reality is that nursing is also evolving, is also being transformed. So you find that nursing, as much as it has been a calling, first and foremost, we like to save the patients, we love people, but it's also now becoming a profession. So therefore, it should be treated as a profession, as part of evolution. The issue of attitude, or negative attitude or bad attitude of some nurses towards the patients, we cannot condone that as an organization, as DINOSA. However, also the reality being is that the nurses, I think has been put very well by previous speakers, nurses are suffering from what is called a burnout syndrome, whereby they are really not coping with the workload, and that, of course, that may affect the function of the nurse, because the nurses are overwhelmed by the work. So that is the situation I faced with, but I won't elaborate. I think that has been elaborated more, what of the causes of that.
All right, Kaya, thank you very much indeed. Look, the death of a child of any age is hard and agonizing to deal with, right? It is even more stressful if alleged medical negligence could be the cause of that death. Some Gauteng mothers, a decade later, are struggling to come to terms with the loss. And they say they lost their newborn babies at Tembisa Hospital. And no one, they say, is willing to take responsibility. Take a look.
A grief-stricken mother. 50-year-old Teresa Klaba lost her baby almost a decade ago. She was admitted at Tembisa Hospital at the time.
There's this experiment that I'm making a balloon catheter. When's the experiment ngam nangomdana? All in all, umdwana kwathiwa kimi umdwana sekashonile. Angidli amaphilisi ngalithola nje kayi-1.
She's not the only one in pain. 34-year-old Busisiwe Luthuli says she lost her baby at the same hospital in 2012.
He died ngabhala incwadi after the funeral, find out what happened to umntanam. I submitted Tembisa Hospital. There was no reply. Bangitsho ukuthi it's because bachinja management yakudala iyaphuma kuza entsha. Till today akunanto engayithola. Till today I don't know ukuthi umntanam wabulawa yini.
Community leaders claim no one is willing to take accountability.
Because we've written a memorandum to the Tembisa Hospital. Some of the issues that we had raised on the memorandum, negligence, Tembisa Hospital, the alleged negligence, the community experiences, adi healthcare workers, Tembisa Hospital. Up to date, no one has taken accountability.
Even more shocking, the Gauteng Health Department this week reported to the provincial legislature that almost 800 babies died at the Tembisa Hospital between 2020 and this year, citing the lack of oxygen and congenital anomalies, among other factors.
At Tembisa Hospital, for instance, the SIU found that about 1 billion rand was misappropriated. Now, I can imagine if that 1 billion rand went into patient care instead of into greedy people's pockets. Now, it's not just Tembisa Hospital. I think there's a scam at virtually all the hospitals. And if we've got decent management in and we cut out the corruption syndicates, I think then we won't have deaths that could have been avoided, because that's what the issue is.
Several attempts to get a response from the Tembisa Hospital have yielded no positive results. For It's Topical, I am Xolani Ringane, SABC News, Tembisa.
All right, Xolani, thank you very much indeed for that report. Let's take it back to our guest, Michele Clarke. When you see reports like that of almost 800 babies dying, various reasons given, lack of oxygen, congenital anomalies, it's disturbing. Where's the solutions here?
It's terribly disturbing and heart-wrenching when you listen to patients and to parents that have been subjected to this, and that's happened to them. Well, first of all, it's mismanagement within the hospitals. It's employing certain staff members that are not trained adequately. And I will just take you back to, we did an oversight visit at the Eastern Cape province this weekend and 6 months ago. And in the neonatal ICU, the professor that was in charge of that ICU said to us, he's only got 6 staff members in that ICU unit. And when that ICU unit is full, he's actually got to say to parents, I'll have to transfer your babies to the general wards and prepare yourself for the worst. I mean, imagine getting that message as a parent. Now, the private sector has acknowledged that nurses need adequate training, and I mean we have a shortage of nurses between 26,000 and 62,000 nurses between public and private sector. Private sector has said they have waited for government to change the legislation and minor changes in order to assist in training nurses for public health care. Now, government's just not moving on that matter, and I think that is an incredible injustice that they're not taking up that offer. Number 2, you get people like Babita Decoron, who exposed the fraud and corruption at Tembisa Hospital, and nothing happened. Absolutely nothing happened. I mean, those service providers have not even been blacklisted. And as my colleague Jack Bloom said, if we take away all the fraud and corruption that are happening at our hospitals and the mismanagement that we have, because there's no consequences relating to that, we would probably start seeing a far better picture in terms of healthcare.
Right.
Then there's the matter of accruals and medical legal claims, which is deducted of each and every province's budget in the beginning of the budget cycle. And that normally reduces their budget down to 50% less to operate with, which, you know, they just cannot continue working in that environment.
Yeah.
And Professor Michele himself, the previous ombudsman, said that healthcare in our country, our hospitals do not align to the ideal clinics document that they should align to in order to operate in. And that is very concerning to the services we provide to South Africans.
Dr. Crisp, I understand that NHI will be a process. And I'm not naive to believe that it is the silver bullet that will eradicate all issues. But when you hear what Michele has to say, you saw the reports, would we get better with this system? Would these things, you know, would measures be in place in order to put paid to certain issues that you saw?
So, Blaine, thanks very much. Look, to try and summarize what a lot of people have said, all the speakers have said very important and direct and correct points. But we're missing what we are saying here. The diagnosis tells us there are nurses sitting at home. We get told we need to train more nurses. Why? So they can sit at home. We hear that we don't have enough staff in a hospital, and I was on the same oversight visit in Gqeberha, so I agree, and that's what it is around the country. But the budget gets cut by 1.5% while increasing the tax credits to the private sector, and the private sector putting up the contribution rates every year. So you're getting a decreasing amount of money available in the public sector while it's increasing in the private sector. We heard from one of the speakers saying the vast majority of healthcare workers are sitting in the private sector. That's the problem. We have this massive inequity. We are not the same as other countries. We have what's called the Gini coefficient, of a measure of inequity in society, higher than any other country in the world. That's the point. That's what we have to fix. Those socioeconomic discrepancies that Glenda was talking about that contribute to where we are. We have to fix those things, but you can't do it all at once, and you can't have your cake and eat it. So you can't have just a private sector where we allow the circumstances to pull the resources and to look after a small number of people, and then the rest must suffer. We have 400 public hospitals, 265 private hospitals, acute hospitals, but we have patients in the very area that Mr. Bloom and the honourable member from the DA were talking about, who must drive past 2 or 3 private hospitals to get to Tembisa from Diepsloot and other communities in Johannesburg. And somebody said, why don't we build a new Kempton Park Hospital or rejuvenate the old Kempton Park Hospital? Why don't we just send the patients to the nearest private hospital? They're all underutilised. They've all been asking us during COVID to work more closely together. The answer is the legislation is too difficult, and the way in which the budgets are structured is too difficult. This is what we want to do in the NHI. We want to use all the resources for everybody in a fair way, so that we all get the healthcare that we need, when we need it, where we need it, without incurring financial hardship.
Doctor, final word to you. Solutions?
Yeah, absolutely. I mean, I was going to draw on our COVID experience where it didn't matter that you did not afford private healthcare. If you needed an ICU at a private hospital, that was in place. That is what I'm talking about, that our resources in private and public sector are critical. The one thing that, if there are many issues, there's not just one problem, but what people outside of health sector may not know is that we really do not have a common way of measuring quality in this country. So if we do not have a standardized way of doing that, what is quality? To someone, quality is how long the queue is, and it's obviously they tend to be longer in the public sector. It's about the hotel side of the hospital. It's about the food. Is there a TV in my room? Bedside manners. All of those are important. But when it comes to health outcomes, we don't really we aren't moving fast enough. After the health market inquiry, there has been some movement, but it's still different players doing it differently, so it doesn't help. But from the public sector perspective, the Office for Health Standards Compliance, there certainly is a model that are 7 different key priorities that must be measured, that must be applied, and there should be consequences for facilities that do not meet that. And my opening line about ideal clinics, they also subjected to this. The issue is to fast track, make sure we standardize, then we can measure healthcare the same way.
Doctor, thank you very much indeed. Always instructive. Dr. Crisp as well, Michele, Clarke, as well as a digital audience. Now, unfortunately, we run out of time, but appreciate your contributions on this program. Lots to discuss. We will continue discussing this on the SABC news channel going forward. We need to flesh out what NHI means to you and me. It's important. And thanks to all my guests once again. Here's my take, and here's the bottom line. We need our healthcare workers. The height of the COVID-19 pandemic wasn't that long ago for us to forget how much we needed them, right? Nurses and doctors on the front line, regarded as heroes. And where there is heroism, there's always hope. And there's no room for playing partisan politics when we talk about people's lives. Our leadership needs to listen to those who are at the coalface on a daily basis, working with or without the tools of trade. Listen to those who use public health facilities on a daily basis. Courage is what it takes to stand up and speak. Courage is also what it takes to sit down and listen. Winston Churchill. The lesson from COVID: no one is safe unless everybody is safe. Our lives are interlinked. Our health is interlinked. So let's become more connected to this country's consciousness and do what's best for her citizens. And that's my take. If you missed anything, be sure to watch this episode of It's Topical on YouTube. Sports Live up next. Big focus on Clive Barker. You don't want to miss that. If you're watching a repeat of this program, then as always, the news continues. Until next week, take care. Bye-bye.